My name is Husain Borki and I am second year medical student. What's your name?
My name is Murtuza.
And can I know your age?
23.
Okay. So today we are going to perform lungs and thorax examination. So this will require me to examine your chest and lastly we will auscultate your chest using stethoscope. So does that sound okay?
Yes.
Okay. Now what we are going to do is I am going to step out of the room and you are going to remove your clothes above your vest. So does that sound okay?
Yes.
Okay, so let's proceed.
Okay.
Observe the shape of the chest, which is normally wider than its deep. The ratio of the anterior superior diameter to the lateral chest diameter is usually 0.7 to 0.75 up to 0.9 and increase with aging. Assess the respiratory rate for tachypnea. Inspect the patient's color for cyanosis or pallor. Recall earlier irrelevant findings, such as the shape and color of the fingernails and also the color of the lips. Inspect the neck during inspiration. Is there contraction of the accessory muscles, namely the SCM scalene muscle or supraclavicular retraction? During expiration, is there contraction of the intercostal or abdominal oblique muscle? Is the trachea midline? Standing in a midline position behind the patient, note the shape of the chest and how the chest moves, including the following: deformities or asymmetry in chest expansion, abnormal muscle retraction of the intercostal spaces during inspiration, most visible in the lower intercostal spaces, impaired respiratory movement on one or both sides or a unilateral lag or delay in movement. As you palpate the chest, focus on areas of tenderness or bruising, respiratory expansion, and fremitus. Identify tender areas. Carefully palpate any area where the patient reports pain or has a visible lesions or bruises. Note any palpable crepitus, defined as a crackling or grinding sound over bones, joints, or skin, with or without pain due to air in the subcutaneous tissue. Assess any skin abnormalities such as masses or sinus tracts. To test chest expansion, place your thumbs at about the level of 10th ribs with your finger loosely grasping and parallel to the lateral rib cage. As you position your hands, slide them medially just enough to raise a loose fold of skin between your thumbs over the spine. Ask the patient to inhale deeply. Watch the distance between your thumbs as they move apart during inspiration and feel for the range and symmetry of the rib cage as it expands and contracts. This movement is sometimes called lung excursion.
Okay, that's it. Now I am going to palpate the vibrations. So you have to speak 99 continuously when I say you to start. Is it okay?
Yes.
Palpate both lungs for symmetric tactile fremitus. Fremitus refers to the palpable vibration that are transmitted through the bronchopulmonary tree to the chest wall as the patient is speaking and normally symmetric. Fremitus is typically more prominent in the interscapular area than in the lower lung field and easier to detect over the right lung than the left. It disappears below the diaphragm. To detect fremitus, use either the ball or the ulnar surface of your hand to optimize the vibratory sensitivity of the bones in your hand. Ask the patient to repeat the words 99 or 111.
Now can you say 99?
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay, now you can stop.
Precaution is one of the most important techniques of physical examination. Precaution sets the chest wall and underlying tissue in motion. producing audible sound and palpable vibration. Percussion helps you establish whether the underlying tissue are air-filled, fluid-filled, or consolidated. The percussion below penetrates only 5 to 7 cm into the chest, however, and will not aid in detection of deep-seated lesions. Hyperextend the middle finger of your left hand, known as the pleximeter finger. Press its distal interphalangeal joint firmly on the lung surface to be percussed. Avoid surface contact by any other part of the hand because this dampens out vibration. Note that the thumb and the second, fourth, and fifth finger are not touching the chest wall. Position your right forearm quite close to the surface. With the hand cocked upward, the middle finger should be partially flexed, relaxed, and poised to strike. With a quick, sharp but relaxed wrist motion, strike the pleximeter finger with the right middle finger, called the plexor finger. Aim at your distal interphalangeal joint. Your goal is to transmit vibration through the bones of this joint to the underlying chest wall. Use the same force for each percussion strike and the same pleximeter pressure to avoid change in the percussion note due to your technique rather than underlying findings. Strike using the tip of the plexor finger, not the finger pad. The striking finger should be almost at right angle to the pleximeter. A short fingernail is recommended to avoid injury to your knuckles. Withdraw your striking finger quickly to avoid damping the vibration you have created.
Now can you put your arms on your opposite shoulder like this? Okay.
Identify the descent of the diaphragm or diaphragmatic excursion. First, determine the level of diaphragmatic dullness during quiet respiration. Holding the pleximeter finger above and parallel to the expected level of the dullness, percuss downward in progressive steps until dullness clearly replaces resonance. Confirm this level of change by percussing downward from adjacent areas both medially and laterally. Now estimate the extent of diaphragmatic excursion by determining the distance between the level of dullness on full expiration and the level of dullness on full inspiration, normally about 3 to 5.5 cm.
Is it okay if I mark with ink on your back?
Yeah.
Okay. Now when I say you to breathe out and hold it. Okay? Can you breathe out for me? Okay. Now can you breathe in? Okay. Thank you. Okay. Okay. Now take deep breaths with your mouth.
Auscultation involves listening to the sounds generated by breathing, listening for any adventitious sounds, and, if abnormalities are suspected, listening to the sounds of the patient's spoken or whispered voice as they are transmitted through the chest wall.
If you feel uncomfortable, inform me. We will take a short break. Now, can you say E for me?
Okay. E.
Egophony.
E.
Ask the patient to say
E.
E. You will normally hear a muffled long E sound.
E. 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 E.
Okay. Can you say 99 for me?
Okay. 99.
Bronchophony. Ask the patient to say
99.
99. Normally, the sounds
99.
transmitted through the chest walls are
99.
muffled and indistinct.
99.
Louder voice sounds are called
99.
bronchophony.
99. 99. 99. 99. 99. 99. 99.
Can you whisper 1, 2, 3 for me?
Okay.
Whispered pectoriloquy. Ask the patient to whisper 99 or 123. The whispered voice is normally heard faintly and indistinctively, if at all.
Observe the shape of the patient's chest and the movement of the chest wall. Note deformities or asymmetry of the thorax. Abnormal retraction of the lower intercostal spaces during inspiration or any supraclavicular retraction. Local lag or impairment in respiratory movement. Palpate the anterior chest wall for the following purposes: identification of tender areas and assessment of bruising sinus tracts or other skin changes. Assessment of chest expansion. Place your thumbs along each costal margin, your hands along the lateral rib cage. As you position your hands, slide them medially a bit to raise loose skin folds between your thumbs. Ask the patient to inhale deeply. Observe how far your thumbs diverge as the thorax expands and feel for the extent and symmetry of the respiratory movement.
Now can you say 99?
99, 99, 99,
Fremitus is usually
99,
decreased or absent over the
99,
precordium.
99, 99.
Okay.
The heart normally produces in area of dullness to the left of the sternum from the third to the fifth interspaces. Pricus for liver dullness and gastric tympani. Listen to the chest anteriorly and laterally as the patient breathes with mouth open and somewhat more deeply than normal. Compare symmetric areas of the lungs using the pattern suggested for percussion. Listen to the breath sounds, noting their intensity and identifying any variations from normal vesicular breathing. Breath sounds are usually louder in the upper anterior lung fields. Bronchovesicular breath sounds may be heard over the large airways, especially on the right. Identify any adventitious sounds, time them in the respiratory cycle, and locate them on the chest wall. If indicated, listen for transmitted voice sounds.